Hi everybody, nice to see you all. Welcome back. Okay. See you all again this new year, 2017. It's going to be a good year for us as a faculty. So tonight we're pleased to introduce Dr Ian Jennens. Ian is an infectious diseases specialist, that's our occupational physician. He's an infectious diseases specialist at Royal Melbourne and also works privately in private practice. I've known Ian for many years, haven't we? Yeah, from medical school days. But more recently, Ian and I have had the interaction with looking after a joint patient, and it was this that stimulated my interest in asking Ian to speak tonight on a couple of things in infectious diseases, and we haven't had infectious diseases for a long time, so I thought, good opportunity. So I'm just going to open up tonight with just a few words, just a few slides about the patient, just to sort of stimulate a bit of interest and see how it goes from there, and then Ian's going to take over. So this was August 2016. This was an Age headline about a small outbreak of Q fever in Melbourne's west. So this is a guy that I look after from the Geelong refinery. His name's DC. He's a 55-year-old worker. He manages our LPG plant, which is part of the refinery or an offshoot from the refinery. He actually lives in Brooklyn in the western suburbs of Melbourne. And whilst he was on holidays in July 2016, he developed a flu-like illness, fever, sweating, neck pain, headaches, low appetite. He was a bit dehydrated and felt really pretty dreadful and quite unwell. And he was like that for a few days. He went to see his GP, who ran quite a few tests and things. And one of them was his UNE's creatinine, and he was found to be markedly hyponatremic. But the GP had no idea what was really wrong, but he was really quite hyponatremic, so he sent him to Western General, where he was admitted for another few days. They ran a whole series of tests on him as well, and they still didn't know what was wrong with him. Nobody knew. So they treated his hyponatremia and they sent him home. He was told he had a flu-like illness and they just sent him home. He continued to be really unwell. Fatigue was probably the most marked symptom by this stage. And he remained off work for 4 weeks. So I wasn't aware that this patient, or DC, who I normally see because he's got a bit of a stuffed ankle, poor fellow, from an old work injury years ago, I wasn't aware that he'd even been sick until he came back into the medical centre and told me the story. And at that appointment, he said to me, could it be Q fever? And I'm going, why would it be Q fever? Why on earth would this be Q fever? And we talked about all this possible connections, where he could have got it from. He's got a family who've got a family farm. And we discussed how long ago it had been since he was last there. That was 3 months ago. They do have sheep and grain, but there'd been no history of Q fever up in that area on his family farm, and he hadn't been there for 3 months. Occupationally, no livestock on neighbouring land. The LPG plant sits in a bit of flat plain near Lara, surrounded by grass paddocks, but there's no cattle, sheep or anything else on it for ages, for miles. There are occasional livestock freight trucks that go up and down on the adjoining road. But he said, what about the meatworks up the road? I've heard that they've had Q fever, and I'm about 1.5 kilometres downwind from the place in Laverton. Could I have got it from that? And I said, oh, geez, I just really don't know. I don't think, I'm surprised that that's what it will be, but look, go and see your doctor. He didn't want me to treat that aspect, and I wasn't that keen on getting involved either. Go and see your GP again and get the test done. And he did get the test done, and lo and behold, he has Q fever. So these were some of the questions that were raised by me. He steadily got better. He was given treatment with the appropriate antibiotics. Fatigue is still his major problem. He did come back to work at about 5 weeks, I think, after his initial onset. On a graded return to work initially, and then we put him back into full-time. He's in a managerial role, so a lot of it's in office-based stuff, and he can self-pace himself at work quite well. So he's managed to return to work extremely well and he's back to normal duties. But in many respects, it was quite an eye-opener for me because I'm going, well, how come he's got Q fever? How common are non-occupational cases of Q fever? And I was surprised to find when I did a bit of research, not uncommon, in fact. There have been outbreaks in communities. It's come from some sort of a source. It's been transmitted by whelping dogs, kittens, kangaroos, pigeons, a range of different creatures other than just our cattle and sheep and goats. And I also was interested in the association of Q fever with hyponatremia, and apparently they can get an inappropriate ADH syndrome as part of the features. So if I'd known that before, maybe I would have said to him, this could have been Q fever. So now, over to our expert, Ian Jennens.
Thank you, Andrea. It's nice to be called an expert occasionally, which is really, really good. Now I've just got to close this one and open my talk. I'm doing well so far. And full screen is that one. Yeah, so I'm not quite sure whether Andrea recommended that he come and see me. His GP sometimes send me some patients, but he might have said, oh, I know diseases, doctor. And you didn't say, I remember one when I was training. Yeah, good. Okay. Yeah, he's an expert. Yeah, that's right. So thank you very much for sending him along. And Andrea took this opportunity, obviously, as she said, to get me to come along and talk about Q fever, and I'll go through a bit of the history and a bit of my experience working with Q fever. And she also added on, well, it might be nice to talk a bit about Zika as well, just at the end, because that's something that's pretty topical. And I'm not sure how much experience or how many of you in the room are involved with Q fever or doing occupational things in abattoirs and stuff like that. Quite a lot of people. Good, excellent.
We do all the immunisations.
Yes, yeah. Excellent.
We've only got through this.
Well, there's probably a few from that, yeah, that Brooklyn outbreak that got through the net. There's less getting through the net now than there used to be. Let's put it that way. And in fact, I guess from the Q fever point of view, I've sort of had a fair bit of involvement in the whole Q fever and occupational health story. I used, as a registrar and then working as a junior consultant at Fairfield Hospital, we used to see acute Q fever and treat it and follow up people with Q fever. And Fairfield closed, I've been working at Royal Melbourne, and somehow people seem to keep sending me patients, and the insurance companies quite often send patients for reports. So I tend to see more people that have been already diagnosed with Q fever rather than acute cases, I guess. But at Royal Melbourne, we've had a few acute cases come through recently. We used to see more in the old days. So I've seen quite a lot, and in fact I was asked 10 or 15 years ago by David Fish, was he a occupational health person, to help with writing up guidelines for infections causing fatigue syndromes, because the old guidelines didn't have any criteria to work out points attributable to fatigue syndromes. And the occupational physicians had to look at anemia or heart failure and try and assess fatigue based on those points. So there was a committee set up with neurologists and gastroenterologists, and I was on that committee to try and write up guidelines for fatigue, particularly because of the problems in Q fever. So I've got some background with this. And then I wrote a hell of a lot of reports for the insurance companies and things like that. And in the old days, it was really quite difficult to convince doctors and insurance companies that people weren't just skiving off and not wanting to work, weren't just bludgers, that they actually had fatigue syndrome following the Q fever. So that's some of my background. So I guess I am a bit of an expert. Q fever, the illness, was first described in 1935 in abattoir workers up in Brisbane by a Dr Derrick, and he described this classical febrile illness in the meat workers. And that interested some microbiologists and immunologists at the time, including McFarlane Burnett, down in Melbourne, and he and Mavis Freeman isolated rickettsial-like rods from these patients that were collected up there in Queensland. And at the time, in 1935, a chap in Montana who was studying Rocky Mountain spotted fever, a rickettsial disease, also found a different agent, which he called 9-mile agent. And that research was continued by a guy called Cox. So this organism had its name changed to Coxiella burnetii to give credit to both Cox and Burnett in finding the organism. So there's a lot of Australian history involved, medical history involved in Q fever. This is a bit of boring microbiology, which I'm certainly not an expert in, but the important points are that it's obligate intracellular bacteria. So it's not a sort of pus-forming bacteria that you get gram-negative sepsis syndromes or abscesses and pus and things like that. You breathe it in, it gets inside macrophages and lives inside there quite happily. And then it induces a cytokine response from activating the macrophages, and that's what produces the high fevers and temperatures and aches and pains. So I think of those sort of organisms, there's a whole series of these unusual intracellular organisms that cause high fevers and temperatures. People look really sick, but people's white cells are normal. It doesn't cause a high white cell count. So those sort of intracellular organisms don't produce a neutrophilia. So people think, oh, it's not a bacterial infection. But it does produce a decent CRP rise, so 100, 200, 300, higher than you'd expect with a virus. So it's a good clue if you've got a high CRP normal white cell count that it might be one of these unusual organisms. It's sort of related, if anything, to Legionella pneumonia. It does mutate through different forms, which really annoys everyone, or annoys me. There's phase 1, phase 2 forms and a spore-like form. And the phase 1 form, it's the virulent form. You find it in nature, in infected animals and humans. And there's a non-infectious phase 2 form. And this has sort of led to these different phases that things can move between, so that people, when you do serology, at these days you're just getting an IgG or an IgM, basically now like an ELISA. But if you want more detailed serology, you ask for phase 1 and phase 2 serology. And that's to monitor someone to see if they're developing chronic Q fever. So we still ask for that sort of extended Q fever serology. But most labs won't do it unless you ask. They just do a IgG and IgM to help you make a diagnosis. So it's found worldwide, all around the world. This talk actually I think I made 10 or 15 years ago for the occupational health talk. And it was about 500 cases a year in Australia, and I thought, I'd better look that up and see if it's still current. And it's still about 500 cases per year, despite the vaccination and things like that. Most of that's still in northern New South Wales and southern Queensland, where the disease is really endemic, if you like. And most common hosts that people catch it from are the goats and cattle and sheep. In Victoria, back in the 80s or in the 90s and 2000, probably, well, 80s and 90s, most of the cases were in abattoir workers. It was usually when cattle and goats were coming down to be slaughtered in Victoria. So there wasn't really Q fever endemic in the Victorian livestock flock, and I think that's still largely true. Goats is probably a different matter because of some of the goat farming, which we'll talk about. So most of our outbreaks in the abattoirs seem to happen after they'd imported animals for slaughter from New South Wales and Queensland. Whereas up there, it wasn't just the abattoir workers that would get sick, it'd be other farmers and vets and other people who were involved with animals. Whereas down here in Victoria, 90% of the cases were in abattoir workers. That was back 10, 20 years ago. Things have changed a little now. And in the abattoir workers, anyone in an abattoir can catch the disease, but the highest risk were the workers working on the killing floor, opening up the animals, especially if they found that they were pregnant cows or goats they were opening. So the amniotic fluid and the placenta have got the highest burden of organisms. So outbreaks have occurred when the animals are giving birth, and parturition is a high risk sort of time. And we've been talking about the Q fever in the animal industry, but in fact there's a native vector of the kangaroo Andrew was talking about, and a lot of other native animals, so they can find antibodies in a lot of kangaroos and macropods to show that they've been infected, and it's probably transmitted with ticks as well as with birthing. And occasionally human cases are thought to be caused by tick bites. So as I've mentioned, it's almost all cases you're breathing in the organism, it's getting into the lung, into the macrophage in the lung, setting up an infection. It's highly infective, so that you only need breathe in one organism for it to set up an infection. And because of that, it was one of the bacteria that had been stockpiled to use as germ warfare. Wouldn't be a great agent in the sense that it's got a long incubation period of 2 or 3 weeks. So it's not something that causes a problem straight away, but it does make people pretty sick. But it's because it's so infective, it's one like anthrax and plague and bubonic plague and those sort of things, and spread by aerosols. It's a good one to use in germ warfare. This was an article, I think, back when I was at Fairfield Hospital. You can probably just read the title, called Poker Players Pneumonia, and this is sort of one of our favourite epidemiological articles in infectious diseases, where you can't actually see the graph in small print over here, but there's about 12 players of poker in Nova Scotia, Canada, that would meet every week and play poker, and there were cats under the table one poker session that was giving birth to kittens. And in the weeks following, 8 of 12 of these poker players developed Q fever. And interestingly, in most of the world, pneumonia is one of the common presentations of Q fever. 70% of people with Q fever have pneumonia. But in Australia, it's about 10% or less. So it must be slightly different strains in Australia, but we have a distinct, it's unusual to have a pneumonia with Q fever in Australia. So this was a lovely article called Poker Players Pneumonia, with birthing kittens under the table. So you can't catch Q fever from another person, coughing and all that sort of thing. It's really not spread, although there are, one of the complications of Q fever is orchitis, and there are some case reports of abattoir workers' wives who've developed Q fever, perhaps from sexual transmission, although it could be from aerosolising from washing their clothes or something like that when they come home from work. So it's not all that clear, but it did seem to happen in the patients who had orchitis. But usually, and the other place where there's been exposure is in maternity ward. A woman with Q fever delivering a baby, and the obstetrician developing Q fever 2 or 3 weeks later. So human placenta, human amniotic fluid will have the same number of organisms as animals as well. So there is some occupational exposure there. But usually most of the time there'll be some contact with animals or some occupation that puts you at risk of Q fever. But it's probably, in Victoria, as I said, it was almost always abattoir workers, and any abattoir worker that came down with a flu-like illness, Q fever was top of the list. It wasn't going to be flu, it would have been Q fever. Now most are vaccinated. Some get employed before or start working before they've actually had their vaccination, or that used to happen. We've had quite a few cases in recreational shooters, people going up to Queensland, New South Wales to shoot wild pigs, wild goats, and then slaughtering it, cutting up the meat, bringing it back and freezing it. So we've had contact that way. The biggest problem really trying to prevent transmission in abattoir is that really anyone that goes into an abattoir could catch Q fever if it's around. As I say, it's highly infective. It's not just the meat workers. So I can remember a chap admitted to Epworth in his mid-40s, with high fever, normal white cell count, high CRP. And I thought, that's an odd illness. What sort of work do you do? He said he was a chef. I thought, well, that's pretty safe. Or a cook. I said, well, that's pretty safe. I don't think you're going to catch anything like that. And went back and wrote my notes, and I went and asked him, whereabouts do you actually cook? And he said, oh, I run the canteen in the abattoir. Oh, okay, Q fever. So it is important to actually know where people work, not just what job they do. But over the years, I've seen drivers going in and out of abattoirs, picking up things, high-risk occupation, plumbers who go in to fix things in abattoirs, secretaries who work in the offices, managers, anyone who goes into an abattoir can catch Q fever, and a lot of those don't get vaccinated because they don't think they're at risk. There were a couple up in Albury who were investigated for Q fever, and their only risk was running along the path next to the Murray River, which is just next to the abattoir. So it's pretty likely they caught it there. Yeah.
Is there a sense of how long it, if there's dust that's been aerosolised on a path, is there a sense of how long?
Yeah, look, it probably has to be in the air, unless you're, if you're driving a truck, there's probably bits of Q fever with animals that are infected falling out. Certainly in Europe, there's stories of a mob of cattle walking through a village and a whole lot of villages coming down with Q fever and things like that. So I think it's a fairly immediate event. It's being released and blown away. On his case was, I think he told me 500 metres to a kilometre.
Yeah, about one, I think it was 1.5.
Down,
yeah,
and downwind was only on a hot northerly day. In fact, it wasn't he wasn't on the north side, he was on the south side of the abattoir on a hot northerly day. So I think you've just got to have the wrong conditions where you've got the release of organisms into the air, which obviously isn't happening all the time. It's an intermittent sporadic event, and the wind blowing.
Consulted by a group of railway maintenance workers.
Yeah.
Where the risk is cattle trucks.
Yeah, exactly the same. And we've had the last 3 or 4 cases we've diagnosed with Q fever at Royal Melbourne haven't been abattoir workers or having any risk at abattoirs. They've just been locals in the northwestern suburbs who drive around perhaps behind a truck or with an open-top car or the window open, or driving around Braybrook or something like that. One driving around and living in Gippsland without any obvious animal contact. And, they come into ED, they've got a fever, we don't know what it is. They get sent up to infectious diseases and we just run Q fever serology because we can't think of what it is. And it's probably only been 3 or 4 cases in 3 or 4 years, but I think it's sort of out there sporadically being disseminated from the abattoir itself or from the trucks that are driving around. It's sort of scary prospect, isn't it? But it's pretty low numbers of cases like that.
So how long can the bacteria the soil?
Don't know. It can. I'm sure the spore form does. Yeah, that's right. But I'm not sure if that's an infected form itself. So it's the phase 1 bit from an infected animal that's actually the infected one. But I think the spore does live for a long time.
No, not all infectious is symptomatic.
No, well, that's right. I'm coming to that. Yeah. But we only see the symptomatic ones as infectious diseases doctors. And because I end up seeing the ones that have persisting fatigue, I've got this really dim view that everyone who gets Q fever gets chronic fatigue, basically. Yeah.
Is it a congenital form? I mean, you mentioned some amniotic fluid. Is it a congenital syndrome?
There's certainly, it causes abortions. So the illness will cause abortions in animals, and I think in humans as well. I'm sure if a pregnant woman caught it, that'd be pretty high risk. But I don't think there's a congenital, abnormality syndrome or anything like that. So the joggers, now we've had a few, vets are at risk, but again, most vets think it's pretty low risk in Victoria and parts of Western Australia, but I'm sure up in South Queensland they're higher risk. And farmers, as I say, a lot of them, I don't think have got animals with Q fever on their property, but you get a story that they go to a sale yard where cattle have been brought down to be sold and they're wandering around sale yards. And there's, I think, this news article I found on the web the other night from Queensland, a journalist who spent half an hour at a local show in a sale yard and things like that there, and there were 20 cases of Q fever from that day at the sale yard, and there's a little support group up there for them. Yeah.
Do the animals have any symptoms?
They can, yeah, but not particularly.
From the animals, is it respiratory infection?
It might be tick bites, I suspect. Yeah. Yeah, I'm not sure how the animals transmit it, but certainly there's talk of it being ticks and bites and things like that, rather than respiratory, because humans don't spread it in a respiratory way, so I suspect animals wouldn't either.
And apparently animals that commonly look well.
Yeah.
They're
not. They don't tend to get sick. Yeah, that's right. But the placentas have the high problem. So visiting sale yards or shows where there's animals and that sort of stuff is a bit of a risk. I can remember an outbreak in a cosmetic factory in Geelong where they used to get frozen placentas from animals in to make their cosmetics, and some of the workers in the cosmetic factory. I'm not a big cosmetic person, but just be careful. Just check how many animal placentas are used in the cosmetics. And the biggest outbreak in Victoria in the last few years was up at the Meredith goat farm, where 20 workers at the goat farm, basically, so there wasn't many locals catching it, but it was workers at the goat farm. And there were 5 or 6 reported fairly quickly, and they realised there was an outbreak and they went and vaccinated people. But I think there were about 20 originally, and this comes from the Geelong Advertiser, where the guy who owns Meredith Cheese goat farm, has asked the rickettsial lab down there to try and fast-track making a vaccine to give the animals, to give the goats, to try and block it. So in Europe, which I'm just about to come to, southern Holland, they beat our 25 cases. Between 2007 and 2010, there were 4,000 cases of Q fever in southern Holland in an intensive goat farming region. And only about 5% of these were actually goat farm workers. Most were people who lived in the high-density suburbs around the goat farms. So it's all non-occupational exposure, something like 4,000 cases over 3 or 4 years. And in fact, they began vaccinating all the animals for Q fever. So there is a vaccine available they can't bring into Australia, apparently. So John Stenos, who used to be a microbiologist at Fairfield, they're getting his photo taken with it and saying they're going to try and make a vaccine, $1 million push to find a Q fever vaccine for animals to save their industry. And as I say, now we saw this outbreak not just in the workers at the abattoir in Braybrook, but in people around the area and people visiting the area and some of the locals around. And I think, in fact, the patient told me, or maybe it's on my latest slide, but he said, it was in the local paper, there'd been this outbreak and this sort of thing. That's why he was sort of asking about it. And when he told his mum said, oh, yeah, it's probably Q fever. Your dad had that. He used to work at an abattoir. It's just you've been just as sick as him. So, in fact, his mum thought he might have had Q fever as well. Then he went off and got tested. Okay, so that's exposure, which sort of hopefully answers some of the questions that you were raising. Yes, I've mentioned this. The organism gets internalised. And the interesting thing is it can actually, it's not just take up macrophages, it gets into the phagolysosome, which is supposed to, it's really acidic environment, it's supposed to kill everything that gets in there. It can actually survive in there for long periods of time. So it actually likes being taken up by things that should kill it. Roy's point, 60% of cases subclinical. So that's important when you're looking at the vaccine, because you can't give the Q fever vaccine to someone that's had Q fever before because of reactions. And so everyone needs testing before they have the vaccine, with serology and a skin test like the old Man-2 test. So that delays people being employed, and people sometimes try and get around that. So 60% subclinical, you pick it up on screening. So the other 40% have a pretty stereotypical febrile illness. They get really sick, they're high fevers and temperatures, headaches, aches and pains, no specific localizing features usually. And so the first few days, they're all tough workers. They think it's just the flu. 4 or 5 days, they're not getting better. They go to their GP who says, oh, it's probably just a virus. They might do an FBE and it's normal. But anyone that works in an industry where it could be Q fever, that's probably the likely diagnosis by that stage. Flu doesn't go on for 5 days with high fevers. Flu, your fever lasts 2 or 3 or 4 days and goes away. So if someone's coming along 5, 6, 7 days, you should be thinking, well, Q fever, but other atypical pneumonias and other prolonged fever syndromes. Some are sick enough to require hospitalisation. I I haven't seen hyponatremia before. I'm not sure if it's SIADH. When people have high fevers, the other possibility is they feel dehydrated. He might have been drinking 6 litres of water a day to try and rehydrate, which everyone seems to think is so important these days, and end up getting hyponatremic from drinking too much fluid. I don't carry around a bottle of water with me. A little bit there. So very low mortality rate. People like DC get better by themselves after about 2 weeks. Their fevers settle down. And only a very small number develop the Q fever chronic infection, where the organism's still living in the body and can come back and cause endocarditis or liver disease. So that's a really uncommon complication. But after an acute illness, 10 to 50% will develop this post-Q fever debility syndrome. That's the term I like to use rather than chronic fatigue. I've mentioned the acute illness, but the incubation period's about 3 weeks, basically. A little bit, 1 week, sort of 2 weeks to maybe 4 or 5 weeks, but it's usually about 3 weeks, pretty typically. I've mentioned self-limiting flu-like illness, severe headaches, chills, drenching sweats, aches and pains, might have vomiting and diarrhoea, dry cough, but pneumonia is uncommon. Hepatitis, abnormal LFTs, very common. In a lot of these illnesses, you'll get abnormal LFTs, but rarely get jaundice, rarely enough to get jaundice, and very rarely getting the severe complications, meningoencephalitis, myocarditis, epididymitis. And in fact, this is quite nicely put together by Dennis Spellman, some of you might know from the Alfred, who worked out at Fairfield in the early days. He had looked at all the patients diagnosed with Q fever between 62 and 81, so it's a bit historical. 100 cases, all were male except one. 100 of the 110 had been working in an abattoir, so that just shows how much it was localised to abattoirs in those days. Acute febrile illness, rarely pneumonia. Most had, well, very few had jaundice, but a lot had abnormal LFTs. They all had fevers, some had big livers and spleens, and 40% reported fatigue illness after their acute illness. And only 3 went on to be diagnosed with chronic Q fever. As I've mentioned, there's usually a normal white cell count, maybe even a low white cell count. Thrombocytopenia may occur. Everyone almost has abnormal LFTs, but really jaundiced. Usually elevated ESRs and CRPs, so it doesn't look like a viral infection. The chronic Q fever is very uncommon. In fact, you know, I can think of a few cases of Q fever endocarditis we've had, and some of them who were never even diagnosed with Q fever acutely and monitored, which is what we do with people. These people just turned up out of the blue with needing valve replacements, and at the time tests were done and showed they had Q fever endocarditis. So the people who get the endocarditis, there's good studies to show it's not the young, healthy abattoir worker. It's older people in the community that get Q fever that have already got a valvulopathy, a valve problem. So it doesn't seem to stick on normal valves. It's like other endocarditis. It sticks on prosthetic valves or already damaged valves in older people. The recommendation is now to someone with acute Q fever is to do a transthoracic echo and see if they've got any valve problems. And if they have, there's a study suggesting you should put them on longer-term treatment to prevent endocarditis. But otherwise, the treatment's just with two weeks of doxycycline. Occasionally, as I've mentioned, it can cause chronic hepatitis or osteomyelitis, endovascular infections of stents. Basically, the diagnosis in the acute illness, and you may get negative tests in the first week of illness, but by the second week or follow-up serology should become positive. So some people have negative serology early, becoming positive. So if you have a rising titer or a high IgG with an IgM or a single phase IgM higher than 256. To diagnose chronic Q fever, it's really over many years that the serology stays high with high IgG levels. So I've got one patient at the moment I'm monitoring after developing acute Q fever, doing yearly tests, and their IgG came down quite nicely, and all of a sudden it's gone back up again. So I've done an echo and can't find very much, but it's pretty suggestive he might have chronic Q fever. I haven't treated him yet. You can do PCR for Q fever, and during the illness is about the only time you'll find it in the blood. reliably. It might crop up occasionally in people with chronic Q fever or endocarditis. And if people have their heart valves taken out, you can do PCR on the valve to try and show it's Q fever. It's not an organism that grows in culture, so you have to look for with serology or PCRs. Treatment's fairly straightforward. In the acute illness, it's 2 weeks of doxycycline, 100 milligram BD. And people do get better. Fevers and headaches settle in 24, 48 hours. So it really makes a difference to treat someone. Don't wait on the serology. If you're suspicious at all, start them on doxycycline and do the serology, and then you can stop it at 2 weeks. And as I say, it may be longer with abnormal valves. Because if you diagnose someone with chronic Q fever, it's really years of treatment with doxycycline and rifampicin, and adding plaquenil, which apparently gets inside these phagolysosomes inside macrophages and alters the pH. So there's studies from the French where they get a lot of Q fever. Adding plaquenil helps cure the chronic Q fever. And obviously you might need valve replacement. The vaccine developed in Australia, a Q fever vaccine by CSL, and there was a guy in Adelaide, going back in history, who's now died in the last few years in his 90s, and he was working up till then, basically, on Q fever, called Barry Marmion. I don't know if anyone knows Barry. Yeah, amazing guy. He was probably the Australian expert on Q fever, and, you know, we'd always ring him and talk to him about problems. Lovely guy. But he developed the vaccine with CSL in '89, tested it. It's actually, it's a killed purified organism. Stimulates antibody response and cell-mediated immunity. Now, I think it's up to, well, I'm not sure how old that is, the 1 in 3.5. It's probably better than that now. Probably most abattoir workers are vaccinated. But in '98, there was about 1 in 4 were vaccinated. And it's pretty good. They claim 100% effective in preventing Q fever. We've had a few cases of people developing Q fever just after getting the vaccine, when it hadn't had time to work, or maybe before they got the vaccine. And it's about, Roy, you might know, is it $80 to $100? I sort of looked up.
No, I don't know the cost.
Yeah. I think I looked up, I Googled Chemist Warehouse. Is that where people get their cheapest things? And it was $120 there. But other sites said it was $100 or $180.
It was free when they first started vaccinating.
I think, yeah, that'd probably be right. Yeah.
It was.
CSL, well, they're a public listed company. They have to make money, I guess.
Yeah, I think that.
Yeah.
Free in Victoria.
Yeah, look, I think it might have been supplied, but yeah, that's right. I mean, that's the cost if you want to have it done. And students at university doing vet science and going on placements in the agriculture and area are recommended to get Q fever vaccine. So I'm sure they're not supplied by the government.
I vaccinated the ones that got them.
Do you? Yeah, the students. Yeah. Yeah.
If the vaccination rate's gone up, but the clinical incidence per year is still 500?
Yeah, that's right. Well, I mean, certainly there's less abattoir workers than there was, and they're the ones that are vaccinated. Maybe we're diagnosing more just from, but as I say, most of it, certainly the rates in Victoria, I can say, are a lot less than they were back then. We had about 80 cases a year back in before or when vaccination wasn't full coverage in the abattoir. It's now, 25 at, we probably get 30, maybe 20 or 30 cases a year now, and some of that's 25 in one abattoir or 25 at Brooklyn in this report. So Victoria's doing all right. Yeah.
This is the lion's share of the cases still in.
Yep, Queensland, New South Wales, yep. In probably 80 or 90% of Australian cases are still in that area in Queensland, New South Wales, where there's obviously a lot more environmental Q fever with the kangaroos and marsupials, macropods and things, and the animals. And ticks, which, yeah, some of it could be tick bites as well, yeah. So we don't really have a lot of transmission amongst animals down here in Victoria. We're not really in the flocks.
What we found is that it was when there was a drought up in the north.
Correct.
And we had plenty of
stock feed, yep.
And they all came
down here, and they were selling them down here because the prices were higher, moving them all down to get slaughtered down in the abattoirs down here. That's right. And that was what the abattoir workers would always say, oh yeah, we had this lot of goats or cattle come down from New South Wales, Queensland, then everyone got Q fever.
Before
yeah.
Before Q fever, brucellosis did the same thing.
Yeah, That's right. So it came in sort of outbreaks when there were droughts, you're right. Okay, so this is what we now move on to, which is the biggest problem, I guess, in occupational health. I mean, diagnosis and treatment of Q fever is one thing, but it's the 10 to 40% people after clinical disease that just don't get better. They never get back to their health. And basically, Marmion described it in a group of South Australian workers in 1996 in The Lancet, in a letter to The Lancet, basically inappropriate fatigue after exertion. So people can do things, but they just feel terrible after working for 10, 15 minutes, have to sit down and rest. If they overdo things the next day, they feel awful. They've got to lie in bed for a few days. They talk about have night sweats, more night sweats usually, and sometimes sweating when they're working. And one guy I remember saying he couldn't work, he had to always work in the cool room. He couldn't go and work outside anymore. He always wanted to work in the cool room because he didn't sweat as much. Aches and pains, myalgias, arthralgias, mood disturbance, can't drink as much alcohol as they used to be able to. We tell them that they're going to improve over the first year or so, and they generally do. And then after that, they don't seem to get any better. They sort of plateau. They get used to their fatigue and they work their life around it better. They're not as anxious and stressed about it, except they still have to go through the whole occupational health, trying to get back to work, people not pushing them to get back and work, telling them they're not working hard enough, and the legal cases to try and get workers' compensation, to get them to pay for their illness and time off. There's a lot of stress involved in all of this, for not just them, but also me writing reports and things like that. And going back, people coming to see me used to, and I'm sure some of you have seen these sort of patients, but these were young, healthy guys working in abattoirs, earning a lot of money because it was hard work and they were physical work and they were, playing in the local footy team and they were active sort of people, to not being able to go to work at all because they just couldn't work because they felt exhausted, trying to get back and playing footy and couldn't, lasted 10 minutes on the ground, had to come off, couldn't get back to play footy. I mean, and getting paid whatever they get paid when they're sick, which is half of what he was earning at the time. So time and time again, the story is exactly the same when I hear these people's stories. And they're not people who don't want to work, they're people who want to go back to work and just can't. And doing physical jobs, I think, is hard. On his patient with managerial work, a lot of them get back to work. But they're older, they're not as physically active. If he was a fitness fanatic, he'd be complaining a lot more. So that was described by Barry Marmion, and at the same time there was another article of non-occupational exposure in England, downwind from an abattoir, where 40 or 50 people in the local community developed Q fever with the same rates of this chronic fatigue and chronic illness. So it's nothing to do with trying to get work cover and things like that. So I just wanted to share one case with you as well, who I saw a year earlier than your case, but also lives in the Brooklyn area and worked. He's an electrician, so he was employed by a company, not by the abattoir, and he was sent in to work for about a month at a rendering plant, which is next door to the meat warehouse. I think they're owned by the same company, and the bits of meat that they can't sell come into the rendering plant, and that includes the offal and all that sort of stuff, so it's all ground up. So he was sent there by his contractor to work at the rendering plant, so no discussion about Q fever vaccine or anything before you work there. About a month after starting there, acute febrile illness, high fevers and temperatures, had 2 weeks off work. He went back to work, struggled back to work a couple of times, and one time a workmate said he might have Q fever. So he went to his doctor and got doxycycline. Serology, probably 2 weeks after that acute illness, was negative, but a couple of weeks later was positive. So clearly this was an acute seroconversion, acute Q fever. And that was in mid-May. I first saw him in August, so after he'd been diagnosed and treated. And he had a lot of fatigue after working and he wasn't doing much. His wife said he didn't get off the couch. But his fevers had all gone. His illness was over, but he just wasn't well enough to go back to work. He was a keen golfer. He's in his 50s, I think, 60. And he just couldn't go out and play with his mates. He pried a few holes, couldn't do any more than that. But very keen to go back to work. forced himself to go back in September on light duties half days, but failed that, couldn't cope with that sort of work even as an electrician. The mediator was called in, who came along to his consultation and sat in the consultation with me. I don't know if that's a usual practice. It's the first time it had ever happened. Yeah, I thought it was too, but anyway. So I think he got a feel of, this guy couldn't do anything at all. In November, he was back 2 days a week on some light duties. He was playing golf, exhausted afterwards and using a cart to drive around. He'd never done that before. Exhausted after a game of golf. I saw him again February last year. He'd failed going back at work. He was off work. Couldn't. In fact, and the big problem was working half days, 2 days a week. They didn't have any work for him, basically, and he couldn't do light duties. Meant he couldn't do anything, basically. So the people said, "No, we don't sack you. There's no point carrying you on." So he was really frustrated. He still couldn't do very much. He's tiring. In May, I saw him really unchanged, not working. He was not doing as much, so he didn't feel as bad a lot of the time. He was pacing himself. And I last saw him in November. He'd spent 3 months retraining, doing a TAFE course in teaching, so he could go and try and do teaching, which he'd managed to do and finish. He just finished his 3-month course, so I don't know if he's got a job yet. But it's a really difficult, frustrating illness in that occupational area, because people aren't exactly the same every day of the week. Some days they feel all right and they feel they can do some things, and then they feel awful. So, and you can't just turn up and work on the days you feel good and say, find me some work. And some days you're feeling so terrible you can't go at all. So there's this fluctuation as well, which makes it really difficult for the employer, I'm sure. So I'm not quite sure what the solution is.
You mentioned Ian about when he was pacing himself,
yeah,
he coped better.
Yeah.
So what sort of advice do you give patients about? Because there won't be people that work with mothers or people managing families.
Yeah.
How do you advise them?
It's hard because when obviously people get frustrated and depressed and they get on various tablets, and it's hard to know what's going on. Look, it's really just finding, it's like in all chronic fatigue patients really, how much energy you've got. You might be able to do a little bit and rest, so taking it slowly, doing a bit of gardening bit by bit or housework, those sort of things. Mowing the lawn, doing little bits of it rather than the whole lot and then feeling terrible for days. Might work. Yeah, look, I know that in chronic fatigue they use that. It may well. But again, there might be... But chronic fatigue is much the same from that point of view. But this has got, all these other features of not being able to drink as much alcohol and reduce libido and all sorts of other... It's not just the fatigue that's the problem, the aches and pains.
Is there any crossover between the post-stability syndrome and chronic Q fever?
Post which syndrome?
Post-stability.
Oh, my Q fever debility syndrome.
Versus chronic Q fever.
The symptoms are very similar, basically. So you may get, with chronic Q fever, with someone still got the organisms and still could develop endocarditis or something, patients will have the same sort of symptoms. They're tired, they're fatigued, they're having night sweats.
The serology would be...
The serology helps, that's right. So in the serology, the IgG, phase 1 IgG, goes up again. So it should be coming down steadily over time. IgMs can last for years, and that doesn't really mean very much. The IgG over time should slowly go down. With serologies, it depends on all sorts of factors in the lab, what number you get. So a lot of the time you ask them to go back and test last year's and the ones before in one sitting and look and see, make sure they're coming down or staying the same. Because numbers 1 year to the next year, if it's just done individually, they can jump all over the place. And it's the same with syphilis serology. The titers can change year to year, even though, and if you run them in parallel, like doing them at the same time, they'll be coming down. So the actual numbers you have to look at it carefully. And the lab in Adelaide will do that. Barry Marming's lab will take out the old one, take a sample of that, take the new one, run them together at the same time to see if they compare. And sometimes they get a report back that's a bit way out, and then an amended report comes along saying, oh, we forgot to do it in parallel and I've done it again, and it's actually lower than that. So it's a tricky business. But that's the way we sort of monitor them. And as I say, one of my patients has gone back up again. He may have been re-exposed. He goes to the odd farm sale and things like that, even though he's not working.
Does that mean
Hang on, one at the front.
Barry Marmion was looking at cytokines like TNF.
Yes.
As a possible marker of debility syndrome, whatever you want to call it. Could you take us on if anything's really happened there?
Yeah, look,
given that other infectious diseases like infectious mononucleosis also have a debility syndrome, I'd be interested if you have any comments about overlap in molecular mechanisms.
Not really. It's sort of been a graveyard of research, as far as I can tell, that people have looked for all different cytokines that indicate markers. Barry Marmion did come up with something about 10 years ago, and I went to a talk that he gave that looked promising. It wasn't a cytokine, though. It was actually... his theory was there were bits of the organism, even though it wasn't alive, still present inside macrophages that were causing some sort of stimulation. And he did come up with a marker, but I can't remember what it was. I haven't gone back to look at it. It's sort of, as I say, it's a chronic fatigue, and the mechanisms has been a bit of a research graveyard, I think. A lot of theories, a lot of ideas, nothing really come to practice. Yeah.
Brucellosis has a similar type.
Correct. Yeah, chronic illness, and I've seen leptospirosis as well.
And they do have a very similar picture. And
again, with brucellosis, there's the chronic illness problem, chronic infection, as well as the post-fatigue.
Yeah, well, that's right.
Yeah. Luckily, we've eradicated that in Victoria. Yes. They still have brucellosis in the wild pigs up in Queensland, so it's still seen in shooters and things like that. One at the back before.
Yes, I was wondering, is there a correlation between delay in treatment and the debilitating
syndrome? Look, I don't know if that's really been looked at. You'd expect there might be, meaning they've had a longer illness at the start. I don't think so. I mean, I think even a lot of the patients I end up seeing don't get diagnosed till a month later, for these recent ones, because they weren't abattoir workers. But now I think doctors in the country, doctors who see abattoir workers, are pretty good at putting them on doxycycline early and not waiting and saying it's the flu and things like that. And I think that might have been the case. Well, I don't know. Back in Dennis Spellman's series, the abattoir workers, whether they were put on treatment early, I don't know. Yeah.
Has anybody looked into the difference in this post-debility syndrome between the non-occupationally acquired and the occupationally acquired?
Not really, except to say that similar rates occur in the two groups.
Well, that's my question.
Yeah. So the early Lancet two letters had similar in the occupational ones in Australia and the non-occupational overseas. And in that Holland outbreak, there's a lot of ones that aren't occupational as well. Yeah.
Well, my experience is that the non-occupational ones, or would be non-occupational ones, as against Q fever and brucellosis, is that exercise just does not work, even if you do it the most very gradual in the infected ones, as against the ones that are non-infected.
And it might also be that the work in abattoirs is pretty physical work, whereas other people who get Q fever in the non-occupational sense find they can do most of the things they want to in life without interfering too much. But I suspect a lot of people, I mean, I've seen people 20 or 30 years after their Q fever come along and say, look, I'm still never got back to 100%. I'm just not as good as I used to be.
That was going to be my question.
Yeah.
Will they ever turn the corner?
Yeah, I don't think so. But I've only seen a few that far down the track. But the ones that I've been following for 10 or 15 years haven't improved, basically. But maybe there's a few that have and don't come back and see me. So again, there's a lot of ascertainment bias in what I'm saying. So don't believe the things I say. So this is just a follow-up only for you on Mr. DC, who has come back a couple of times. He did tell me that illness seems like it was the sickest he'd ever been. So that just gives you an idea. It's worse than just having the flu. Most of us have had flu once when you're pretty sick. Sickest he'd ever been. He went to Western General ED. I think he only stayed overnight. And it was at the end of his 2 weeks, so his fevers had actually just about settled. He was given some IV fluids and Panadol, and everyone feels better with IV fluids and Panadol. I teach medical students. It doesn't matter if they get better with IV fluids and Panadol. It doesn't help you differentiate anything. They always say, they got better with IV fluids and Panadol. His fever settled quite well over the next week, but he was still tired and he thought he might have had Q. And so he's blood tests were all a bit later, and the GP waited until the blood test came back before he treated him. So it was probably 6 weeks after the onset of illness, or 4 weeks after he started doxing. Back at work doing short days, not very physical stuff, fatigue after exertion, still sweats, aches and pains, struggling to get out of bed some days in the morning, reduced libido. In October, so a couple of months later, he felt he was pretty good 2 days a week. He could do fairly normal things, but the other 5 days a week he was achy and tired and felt he'd been run over by a bus. And then late November, he's back at work, but pretty tired at the end of the week, with really minimal exertion. He doesn't do much. If he tries to do stuff, he gets pretty tired and has to rest after about 10 minutes of gardening or something like that. Still can't drink as much alcohol as he used to, still reduced libido. So he certainly, it's only 6 months since the illness, or 5 months. So I think he's hopefully coming back to see me sometime in the next few months. Follow his serology. Yes.
Sorry,
I can do
more questions. And other people who are visiting.
Yeah.
Given that most abattoir workers these days get immunised,
yep.
for the person who's a legitimate visitor, like electronic or person, and given the transmissions by aerosol or by dust, if those people are wearing a P2 mask,
would probably help. Yeah, probably would. I suspect so. It would definitely reduce the chance of catching it. I mean, people probably don't keep it on all the time they're in the environment, though. You know, if they're working there 6-hour days, it'd be hard to know if they'd keep it on all the whole time. But it would reduce the chance, I'm sure. Yeah.
You've got a slide saying the seroconversion rate after vaccines somewhere around about...
The efficacy rate's close to 100%.
So the seroconversion rate is not...
Yeah, no, I don't think... Yeah, that's right. So because it induces cell-mediated immunity as well as antibodies, you might just get enough cell-mediated immunity without actually antibodies. Luckily, I'm not an expert on Zika virus, so this could be very quick if you want to change topic, or I'm happy to stop if you want to all go home. He says, hopefully. Okay. Well, this might actually, Ace, be important if you've got overseas, people travelling overseas for work, I suspect. And it was quite good being asked to talk on Zika, because I could never work out which viruses were in which families. You know, because to me it's not really important. You've got the virus and you do. I know a test, I know the illness, but I never really bothered working things out. And people kept talking about arboviruses and flaviviruses and alphaviruses, and I never had any idea which was which. But apparently, arbovirus is the group name, and it's a acronym for arthropod-borne viruses. So they live in ticks and mosquitoes and things like that. So that's a bit of information for you. And they're divided into the flaviviruses and the alphaviruses and a whole lot of other as well. And the big ones in this group are yellow fever and dengue. We have, and these sort of encephalitis sort of viruses, Murray Valley encephalitis. We have Kunjun in Victoria as well. Murray Valley appears every now and again in Victoria, not very often. They're pretty worried after this big mosquito year at the moment with a lot of Ross River around, and they've got all the sentinel chickens up along the Murray being bled every now and again to see if they develop antibodies to these viruses. And I think that one's come up positive for Kunjun, and I saw a GP, I think she might have been, who'd been up in Wangaratta and then came along with fevers and headaches and got better in the Epworth, whose serology came back positive for Kunjun. Didn't really prove it because she'd had yellow fever vaccine before, so some of the serology might be positive from that, but it was a bit suspicious. And then there's West Nile virus, which is spread from Africa across to America and up through Canada down to Mexico, causing neurological disease in some people who get it. And now we've got Zika virus, which is spread out of Africa across through Asia, Pacific, Americas, which we thought was just a fever, a bit like Ross River, with fevers and a rash that gets better over 4 or 5 days. But it turns out a small number of people get Guillain-Barré syndrome with Zika, and there's the problem with infected pregnant women and microcephaly. So those sort of things became apparent as the virus spread across into areas where it hasn't been before. So if you've got a virus endemic in a population, there's not much transmission because a lot of people have antibodies, so there's not much viral transmission. It moves into a population without any exposure, and you get large numbers of people, mosquitoes carrying the virus, and more infections in that area. So in the South Pacific, they noticed increased microcephaly in retrospect, and when it hit Brazil with large numbers of cases of spread of the Zika, it became pretty clear that the microcephaly was a problem from the Zika virus. And then there's been a whole lot of work since then over the last couple of years, finding the virus in brain tissue and proving that Zika virus is the cause of the microcephaly. So Ross River and Barmah Forest we have in Victoria, but a fairly mild illness, fevers, joint symptoms. But with Ross River, 5 or 10% of people with persisting arthralgias, arthritis and fatigue for a year or two, quite commonly, 5 or 10% after Ross River. So that's could well turn out to be a occupational problem. People sent to Wangaratta for a week and then come back with Ross River. That's occupational exposure, isn't it? Yeah, certainly. And then you get fatigue afterwards. Yeah. So it's transmitted by bites from mosquitoes. I think it's the same one as the dengue virus transmission mosquito, which means it's present up in northern Queensland and Northern Territory. So Zika could get into Australia and be transmitted in those areas. And with climate change and those mosquito populations moving south in the heat, well, probably Sydney will have a big outbreak of Zika or something soon. That'd be interesting. Short incubation period. Most of these are about a week incubation period, just about all of these viral things, and usually gets better over 4 or 7 days of fever. And interestingly, the different thing with Zika is bright red eyes, conjunctivitis, which you see with measles and you see with leptospirosis, but Zika should be on the list if you see someone with fever and arthralgias from an area, conjunctivitis. And post-illness fatigue is reported as well. But with the fetal abnormalities and the Guillain-Barré syndrome as the severe things. And so don't try and remember any of this. If you ever need to look it up, there's the Australian Government website, Department of Human Service, DHS website. Look up Zika virus. All of this comes straight out of that website. I think I've only seen, as I say, I'm not an expert, I've seen one woman who went to a wedding in the Caribbean and came back, got sick on the way back and was diagnosed. She went back to work at Monash Uni, I think, and someone said, oh, you better be tested for Zika, and she went and got tested and she was positive, so came along, but she was better by then.
Is there much of a risk of any infection above 2,000 metres?
No, apparently not. No, well, that's right. Any infection. Well, HIV you could transmit above 2,000 metres. Syphilis. Quite a lot of things I can think of. But some of the Asian countries are still considered high risk or high transmission of the virus. So I thought, interestingly, not just Central South America, but Thailand, Vietnam, Philippines are still considered high risk countries. So I presume the virus has only just moved into those countries. I thought South Pacific would be still high risk, but that's down in the low risk area now. So it's sort of the virus has been through those countries and there's not much transmission going on now. And then there's the ones in the middle. So there's a whole lot of things, what advice to tell these people when they're travelling on the website, which is incredibly complicated, especially if you're a pregnant woman or you're at risk of pregnancy. Basically, to a high-risk country, you should defer travel and you should think about it if, consider deferring it if you're going to a moderate-risk country. So that's the safest thing. And basically, if you're I can't remember what that meant, but if you were pregnant, there must be a bit more on the end here, you were to avoid unprotected sex with people after you got back from overseas to avoid you catching Zika. Sorry? Yes, that's right. So I think that's with your partner. If you were travelling with your partner and been to a high-risk area, you had to not practice. They had to practice safe sex for 6 months. So all women avoid unprotected sex for 8 weeks after return to prevent the woman transmitting it to someone else. So women could transmit perhaps this is the longest time the virus has been found after cases of acute Zika. So to avoid unprotected sex for 8 weeks after return and avoid unprotected sex with a male partner up to 6 months after possible exposure. So men you can find the virus in their semen for up to 6 months. So basically, it's all about anyone who's pregnant or could be becoming pregnant avoiding catching Zika from sexual exposure. And I think there's also bits about travel up to northern Queensland, trying to avoid travel up to northern Queensland if you might still be carrying the virus. And there's a whole recommendations on who to test and how to test in there as well, which I won't particularly go through. But basically, anyone who you think might have Zika, you test, or may have had a sexual exposure to someone with Zika, or might have had Zika. Even asymptomatic pregnant women, there's a higher level of looking to make sure they're not infected. And asymptomatic men or women, you shouldn't test unless they've been to a high-risk country and they're unable to wait the recommended duration to avoid pregnancy or unprotected sex. So that's pretty low threshold to cross, I'd imagine. So they've come up with guidelines of who to test. And basically, there's a schedule of what tests are best at what time of the illness. So you can test by serology, but it takes time. And PCR is only positive really during the acute illness, but it could be positive in the urine. It's a better specimen than blood by PCR to look, and it lasts for longer in the urine. And that's about it, because I'm not an expert on Zika, but happy to field things. Thank you.
Thank you very much, Ian. That was very, very interesting.
Q fever, yes. Yeah,
So thank you very much. Really appreciate it.
Do you have any other questions?
I do have a lot of sympathy for the Q fever sufferers.
Yeah, well, I'm not surprised.
Yeah.
Listen, with Q fever or Zika,
Yeah.
I just left a patient 530
Yep.
who was travelling as a representative all over this Gippsland.
Yep.
And 18 months ago, developed process on knees and ankles and hobbling around.
Yep.
And metacarpo.
Yeah. Through Gips, and he'd been through Gippsland.
And been going all
the
the
way
way
around Gippsland, yeah.
Her area that she purchased as a franchise of this healthcare product.
Right.
Quite
Yep.
old.
Yep.
Found it and all those sorts of. And she's separate. And she's been slowly getting better over the last 18 months.
Yeah.
And she was in for insurance assessment, and I said to her, is it possible you may have lost
Ross River, yeah, it sounds like it could be.
But I didn't know how to advise her.
Well, there's not
get your doctor to test you, but
yeah, it doesn't actually help.
It doesn't help.
No.
The prevalence is probably going to be, I know in West Australia, so it's about 35%.
Yeah, that's right. If you're living in the area, so but a traveller shouldn't have been unless you'd come from an area.
Comes from the area.
Yeah, that's right. So look, at that stage, all you're going to have is a positive IgG. You're not going to have an IgM to say it's an acute illness.
There's nothing good.
Not really, but you can do one and say, yes, it's positive, you've had Ross River at some stage. Your illness and the symptoms since then sound like Ross River. On probability, it probably was Ross River.
Thank you.
I mean,
I've got to write the full subtitle.
yeah, no, that's so on probability. That's why it's a good line.
Any other questions? Okay, well, thanks very much, Ian.
Pleasure.
Very much appreciate you coming along.
Okay. Yes, you too.
When's the next meeting? Oh, okay.